sharing experiences, really important. Learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scan.
Both septal ablation and surgical treatment show good results. It's safe, horrible.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
Good morning. Just so I've got a feel of the audience, just put your hand up if you've got dilated cardiomyopathy. And if you're a relative or a carer of someone with dilated cardiomyopathy? Yeah, brilliant. Okay, fantastic. Well, it's a pleasure to see you all. So I'm going to whiz through this, but please write all your questions down and we'll allow a reasonable amount of time at the end just to go through all the questions. So Perry's touched on definitions, but they're quite important because I think as a patient it's often quite confusing because there's a whole host of different definitions you hear. So if we just start with cardiomyopathy, so all that means is it's a disorder where the heart muscle is abnormal and it's not due to coronary artery disease, high blood pressure valve disease, or congenital heart disease, which is something that's present when you're born. So that's all a cardiomyopathy means. And this is how it all sort of started, trying to describe the different types of cardiomyopathy. And here's dilated cardiomyopathy. So as Perry said, the main pumping chamber, the left ventricle, is bigger than it should be, and it's weaker than it should be. And then you've seen about the new ESC approach, which I think is very good, where they pin it down. How do you present? Was it family screening? Was it an incidental finding? Or was it symptoms? You then describe what you see, and then you describe whether it's hypertrophic, dilated, or this non-dilated left ventricular form. So this is a new classification. And then you have the subtlety of the spectrum of dilated cardiomyopathy. So from people that carry a gene with no obvious expression to just the heart's a little bit enlarged, a few arrhythmias, it's a bit weak, to the sort of full spectrum of weak and enlarged. So there's a whole spectrum of what we see. Anyone been told they had myocarditis here? Yeah, so again, there's quite a lot of overlap here. So myocarditis is an inflammatory disease, and it's a histological definition. So to diagnose it, you really need a biopsy of the heart and to look at it under a microscope. But most of the time we don't do that. We just do an MRI scan, which is a good surrogate. And then if you have myocarditis that's chronic and goes on for a while, then it can give you a dilated cardiomyopathy. What we've seen, I think, over the last 3 or 4 years is a group of people we thought did have myocarditis. We're now reclassifying as a genetic cause. So some of these non-dilated left ventricular cardiomyopathies act very much like myocarditis. So we've reclassified a lot of people recently with that. And then we come on to heart failure. So, I mean, how many of you have been told you have heart failure? Yeah, so I'm just going to spend a bit of time on this because I think this is very important. So heart failure, again, it's just a description. Heart failure is when the heart's unable to generate a sufficient cardiac output to maintain what you need to do. And it can result from any disease, really. But you have to have symptoms and signs. So you have to be tired, breathless, swollen ankles. So without symptoms and signs, you can't have heart failure. And then you split it into these different types. This is on the basis of the pumping function, your ejection fraction. So you can have heart failure with reduced ejection fraction, where it's below 40%, mid-range or preserved, where it's over 50%. And we'll see in a bit, that's important for the medicines we give. So that's the definition of heart failure. And, you know, a lot of people with dilated cardiomyopathy will have symptoms, so you will fulfill the very broad definition of heart failure. But heart failure, when you look at the country, is a different disease. So most people with heart failure have it because they've got heart attacks and coronary artery disease, and they have bad lungs, bad kidneys. So that group of people do much worse than people with dilated cardiomyopathy. You know, the average age of people going into hospital with heart failure is 80 now, and most of them have coronary artery disease. Most of them, I think, have 6 or 7 comorbidities now. So when you read about heart failure, that doesn't really apply to you as a group. And Perry mentioned this, but it's so important. If you take all comers with heart failure that go into hospital, that, you know, the outcomes at 2 and 3 years are very poor. So, you know, up to 50% will die at 2 or 3 years. But if you look at people with dilated cardiomyopathy, 90% are fine at 10 years. So the outcome of dilated cardiomyopathy is completely different to what you read about with heart failure. So, yeah, incredibly important as a group of patients and carers, you understand that. So the outcome of dilated cardiomyopathy with all the drugs and devices these days is fantastic. Okay, and this is important. So how many of you know your ejection fraction, just out of interest? Wow, if I did that 5 years ago, I'd have seen one hand, so that's brilliant. Yeah. And this, look, so this is dilated cardiomyopathy. This is follow-up. This is the starting ejection fraction here. It's about 25. Look, just with 3 months of medical therapy, on average, your ejection fraction will go up by sort of 12–15%. So this is why when you present, we always wait 3 or 6 months before deciding who gets these defibrillators. Medical therapy makes you feel better, but it makes a significant improvement in your ejection fraction. So this is what it looks like on the scan. So this is a normal MRI here. This is the left ventricle here. And you see here, it's much weaker in the way it's pumping. So that's what a weak heart looks like. And here on an echo, that's a normal heart. Well, it's probably got a bit of hokum, actually. And that's dilated cardiomyopathy. That main pumping chamber, it's bigger than it should be. It's weaker than it should be. So that's how we diagnose dilated cardiomyopathy. And I'll go through that, actually. So that's a restrictive cardiomyopathy. That's the difference there. And then, have any of you been told you have an arrhythmogenic cardiomyopathy? Yeah. So this sits within the spectrum of dilated cardiomyopathy. And there's sort of 2 main types here. There's arrhythmogenic cardiomyopathy that affects the pumping chamber on the right, and there's some of the genes that does that. Or it can affect the pumping chamber on the left, and again, here are some of the genes that does that. And often this type of cardiomyopathy tends not to make the heart as big and weak, but gives you a lot of scar in the heart, and that's what gives you the arrhythmias. So that's what now sits on this non-dilated left ventricular cardiomyopathy. So the definitions are tricky, aren't they? And this is the right side. So this is an extreme example here. That's the right ventricle, and you see that lots of little outpouchings, microaneurysms. That's just not moving at all. And that's a more subtle form there. Whereas with the left side, arrhythmogenic cardiomyopathy, you get this scar, which is the white stuff in the muscle there. And you get very different changes on your ECG and things. Okay, so that's the definitions. I've spent a bit of time, but I think it does get quite confusing, so I hope that helps. And how common is it? So dilated cardiomyopathy, I reckon there's about 200,000 people in the country that sit within that whole spectrum, and probably a good half of them don't realise they've got it, because a lot of people will have sort of very little in the way of symptoms. And then what causes it? So this is the causes of a weak heart. And you can see about 30% will be due to this broad term of a dilated cardiomyopathy. And I think this is really important. Dilated cardiomyopathy is just a description. We've seen what it is. You need to know the cause of your dilated cardiomyopathy. And doctors are very bad at this. They just use it as a label, but they don't go to the next level and find the cause. So these are the broad headings. So a lot of it is genetic. Infections can do it. Autoimmune conditions like lupus can do it. Toxins. Alcoholic cardiomyopathy is much rarer than we think. Cocaine, nasty things, but also cancer drugs, antipsychotic drugs can do it. You've got endocrines, the thyroid abnormalities, you've got peripartum. And again, sorry to pick on the audience, but how many of you think you know the cause of your cardiomyopathy? That's fantastic, actually. And how many of you is it genetic? Yeah. Okay. So what we tend to do, we use an MRI to see if there's scar to exclude coronary artery disease as a cause. Or we do a CT to look at the coronary artery. So the era of doing invasive angiograms, unless you've got a lot of chest pain, should be over now. And you can see that's an invasive angiogram, but you get beautiful pictures with a CT these days. And I think once you get over, 50, and if you're doing well with dilated cardiomyopathy, you probably need to start thinking about the coronary artery side of things, because if you get in there early with your statins and all the other things, it makes a big difference at 10 and 20 years. So once you get over 50 and you see your cardiologist, just mention coronary arteries as well. Okay, I'm just going to go through genetics a bit because it is a new era for genetics. These are all the different parts of the cell where we see the abnormal genes. And so these slides are all going to be online, I think, aren't they? So if you want to go back and spend a bit more time looking at the slides, you can probably in a few months. And what's important is if you have an abnormal gene, and the phenotype is what your heart looks like, there's all these other interactions. So the same gene will do multiple different things in the same family. So patients often say, my disease is so mild, there's no point screening the kids. So it doesn't work like that, because you could have mild disease and the children could have significant disease. But it works the other way around as well. So if you've got bad disease, your children might have very mild disease. So there's all these other factors at play. And this is a complicated slide, but this is just showing some genes are very powerful. Most of the family that has some of the genes that we were looking at earlier get a poor outcome. But there's other genes that probably interact with environmental factors. Titin's one of them. So they're sort of like modifier genes. So you need something else. Probably you need atrial fibrillation or drink too much or overdoing the exercise, and you get that combination. And this is important for the family. So I'm going to try and go through this. This is what we always used to think. We used to think if you've got a genetic dilated cardiomyopathy, first-degree relatives have a 50-50 chance. And if we don't find the gene, we just don't know all the genes, so relatives would have a 50-50 chance. But that's not true anymore. So I think we've moved beyond that. So this is where you get that. You can see here's a family tree where the people in black are affected. And again, they've got a 50-50 chance. So that's an autosomal dominant gene that expresses in the family. And that's this rare pathogenic variant. But we have these intermediate effect variants, these small effect variants, and non-genetic factors. So there's a group of people where you have some common variants, environmental factors, that gets you past the disease threshold. But there's 6 or 7 common genetic variants. They're not going to pass through the family. So the rest of the family will be at very low risk. So this is the group when you don't have a positive gene that we're seeing. And because it's that combination of lots of things, the family are much less at risk. And then the other thing you can do is actually use all those common genetic variants, and you can generate this polygenic risk score. So you do a genome-wide association study, you pick the 7 or 8 genes that are important, and if you look at those, that probably accounts for about 30% of the expression in dilated cardiomyopathy. So you'll see a lot of work coming out on this in the next few years, I think. And again, there's something about the accuracy of gene testing. So for long QT and things, it's very good. For dilated cardiomyopathy, it's reasonably good, but you often get these variants of unknown significance where there's a spelling mistake, but you're not sure if that is that's causing the disease. But with those, important you look again 5 years later, because medicine moves on and we often reclassify them. And if they segregate within your family, we can reclassify them. So if that variant would fit with what your disease looks like, you should then, if there's other people in the family with disease, you can see if it segregates through the family. Yeah, so if you have a positive gene, your outcomes are a little bit worse if you look at the whole spectrum of people with dilated cardiomyopathy. But again, if you then pick the genes, there's just a few very high-risk genes, and they're the ones that we get in much earlier for. So it's filamin, desmoplakin, lamin, probably the three we see most. So again, that accounts for most of the high risk we see in gene-positive people. Yeah, and that's just showing the same thing, really. Okay, so what about screening the wider family? So you've got your dilated cardiomyopathy, you've got a positive gene. So how many people have a positive gene? And have your family all had predictive testing? Yeah, so that, you know, the main benefit of having a positive gene is to see who's at risk in the wider family. So, you know, so if you have a positive gene, your first degree relatives should be tested for that gene, or, you know, offered the opportunity to be tested. And it shouldn't be a quick conversation, because there's quite a bit of psychology in often healthy people finding out they then carry a gene that may well give them a cardiomyopathy later. So they need to see a proper genetic counsellor to go through that process. But here we go. Genetic testing, yes. Pathogenic, offer testing with appropriate counselling to relatives. If they don't have it, you can just discharge them. If they do have it, they need ongoing follow-up. So that's the real advantage of genetic testing. And this is what we used to think. Idiopathic DCM, used to think about a third of people would have some abnormalities and a third of them would develop disease. And that's probably still quite true. So in that group, if you're gene negative, risk to the wider family of having an overt cardiomyopathy is probably only about 10%. It's not the 50% everyone used to say. And here, if you look at genetics, so if you ignore that, but if you look here, this is screening relatives. 5 years later, this is healthy. So the vast majority are fine when you look at the relatives. The only ones that develop the cardiomyopathy really are those that are gene positive, or who in their first screen they have abnormal ECG and echo. So if you don't have a gene and a first degree relative gets checked and it's okay, actually you can probably discharge them. That the odds of them having disease is very, very low, and you can tell them to come back if they have symptoms. So we're doing too much testing of relatives if you don't have a gene, and just that constant stress of having tests every few years. And again, testing does depend on a pre-test probability. So ARVC, if you come off the street, your odds are about 1 in 5,000. You know, if your brother's got it with a positive gene, your odds are 1 in 2. So everything has to be framed with a pre-test probability. Okay, I'm going to whiz through that for time. Okay, how are we doing for this time? Okay, let's whiz through. So managing cardiomyopathy. So we do genetics, risk of complications and symptoms. Okay, so non-pharmacological management. So we'll go through this in a little bit, but you need to look after yourself, don't smoke, watch your weight, exercise, have your vaccines. You need to be part of a multidisciplinary team if you're getting symptoms. Let's go through that. And there's certainly some evidence if you're part of this multidisciplinary team, your outcomes are definitely better. Cardiac rehab, who's been through cardiac rehab? It's brilliant, isn't it? I've yet to meet anyone that doesn't benefit from cardiac rehab. So if you haven't, there's a real push nationally for heart failure patients to go through rehab, so ask your GP. And then in terms of medicines, so you need to know your ejection fraction. And the medicines, that the rationale behind them is when you're not pumping enough blood out, you activate hormones because your body thinks you're bleeding, because that's evolution. So it activates your sympathetic nervous system, your renin-aldosterone system, constricts all your vessels, tries to retain salt and water, and that just makes everything worse. So what the drugs you're on do is they stop the dangerous effects of those hormones, so that's how they work. So if you've got mild disease with no symptoms, you're probably not activating those hormones, so you probably don't need the drugs actually. So you need symptoms to warrant the drugs. And you've seen this. So this is what we do. ACE inhibitor, beta blocker, eplerenone, spironolactone, and dapagliflozin or empagliflozin. So if you have an ejection fraction less than 40% with any symptoms, you should be on all of those drugs. And then once you've been on the drugs for a while, do you need an ICD? Do you need a pacemaker? And then there's a few other bits. So that's the devices, that's the drugs. I'll talk about diuretics in a bit. But treat the iron deficiency, ivabradine, hydralazine for a small number of cases, I think. And you can see mortality. If you're on the right drugs, your absolute mortality can go from 60 to something like 8%. There is no other intervention in medicine that does that. It's the most impressive in terms of absolute mortality thing we can do as cardiologists. And just the real life heart failure audit. Everyone in the UK in hospital with heart failure goes into a national audit, and we can see the benefits of all these medicines. Anyone on Entresto? Wow, you're a special audience, aren't you? You're a very select audience, I think. Yeah. Fantastic. So it's like this angiotensin receptor blocker plus sacubitril, which is neprilysin inhibitor, which gives you these other benefits, and that's why you probably see increased benefits with Entresto. Again, that's the trial. They live longer, they feel better. But you had to have symptoms, and you had to have a raised BNP. So you probably have to be unwell enough to drive those hormones to get the benefit. So I think people who are symptomatic benefit more from switching to Entresto. Okay, dapagliflozin. So again, well tolerated. I think thrush is a real problem with dapagliflozin. Doctors don't often tell you that, but just be aware of that. Iron deficiency, there's a trial called Iron Man, so you feel better, less hospitalization if you treat your iron deficiency. It's very common, particularly if you're symptomatic, and you have to measure a couple of things in the blood. So, when you go back and see people, do ask for that. People improve dramatically with all the medicines. They always say, do I have to take them all now? I feel fine. So the short answer is yes, you do, I think, because there's a good trial that if you stop them, most people get worse. So sorry, I'd love to be able to say you can stop them, but you can't. Diuretics. So it's often when you're unwell, you get diuretics, and then doctors are great at starting medicines. They're absolutely hopeless at stopping them. You need the minimum amount of diuretics to not be overloaded. As you get better, just try and stop your diuretics. There's no prognostic benefit from them. You only need them if you're breathless, swollen tummy, swollen ankles. Try and reduce your dose, get off them. It then often gives you room to put the other medicines up. Side effects of drugs. I mean, read the leaflet, but the leaflets contain a million side effects, don't they? So, but there's some common ones. So ACE inhibitor cough is the commonest. If you've got a cough, you want to switch off your ACE inhibitor. Beta blockers, a lot of people struggle. Tiredness, lethargy. There's a beta blocker called nebivolol that's much, much better tolerated. So if you're struggling with your beta blocker, switch it to a different one. Try different ones. Eplerenone, pretty well tolerated, actually. If you're on spironolactone and you're a man, you can get painful gynecomastia, so just watch out for that. Dapaglifozin again, so I think fungal infections are probably the biggest thing I see with that. Entresto, pretty well tolerated, actually. Mental health issues, really common in people with cardiomyopathy and heart failure. Doctors tend not to ask you about that. So be aware, bring it up, talk to each other about it. Cardiomyopathy UK has got a real push on this. But yeah, really important, do raise it. And again, different levels of intervention with mental health issues. the charity hospital can help with the online resources, but there's increasing levels of intervention if you need it. So please do ask for help, because a lot of the time the system won't ask you about this. Sex. Doctors never ask about sex. You've only got your 20 minutes. You're never going to ask about sex. But if you look at the studies, it's really important to people, and it's important to men and women. So, do ask about it. And again, if you look, so do you want to be treated to improve your sexual health? The majority of people do, and there's really good treatments. For men, most people with cardiomyopathy are fine to have Viagra. So do ask. If you can walk up a flight of stairs, you're safe to have sex in terms of how safe it is. Yeah, so do bring that up. It's difficult, isn't it? But do bring it up. Have your vaccines. The jury's out on COVID, but probably should. Don't quote me on that. Still not there with equitable access, diversity, ethnicity, socio-economic. It's still poor. We've just got to be aware and keep trying to improve that. And then here's what you can do as patients. Look after yourself at home. Have a proper blood pressure monitor. Cuff, not wrist. Have one that links to your phone so you can map all your blood pressure. Have a little Alive core thing that can record an ECG. You can email it through to us. That's a little loop recorder you can put under your skin. Proper electronic scales if you're on diuretics. Apple Watch, good these days. It can record an ECG. It can pick up AF. So, get the technology. It's really helpful for us as doctors. I'll whiz through that. Again, we'll start you on all the drugs, but you have to keep your heart failure drugs going. But there'll be a lot you're on that you can stop. Pharmacists, go to your community pharmacy, chat to them about your medicines. If you're on 8 medicines, I'm sure there's a few that can be stopped. People get started on omeprazole when they're 20 and seem to be on it 60 years later. So do keep asking if you can stop your medicines. And there's a few drugs that you should avoid. So salt and water. Unless you're on lots of diuretics and retaining salt and water, it doesn't really matter. You can have as much salt and water as you want. So it's only if you're needing to balance diuretics that we restrict you to 1.5 litres or 2 litres. And if that is you and it's a hot day, you've got to drink more. So just be aware of that. Carers. So again, everything's focused on patients. So carers really struggle as well when you look at both mental health and actual medical health outcome in carers. It's definitely a major factor. So, I think having charities, having carers coming together, chatting, you've got to look after yourself as well. And then I like this. This is life, isn't it? Full health, death at the bottom. Everything we do just is that green line, really. No one's living forever. What we're doing, everything we do is just pushing that green line there. And what you really want is live to 95 and drop dead in the jacuzzi. That's what everyone wants, isn't it? So so just at some point, palliative care may come in, and it's probably worth thinking about that earlier because they have enormous resources. If you've got a defibrillator, you want to turn it off early. You don't want to die having multiple shocks from defibrillators. So they're really difficult conversations, but probably we always have them too late. So again, just be aware of that. Okay, I'm going to whiz through this. This is a pacemaker. So this is your heart. That's the atrium. And then that's the ventricle. So that's how you put a pacemaker. It sits under the collarbone there, and that's so that just looks at your heartbeat and will pace the heart if it's going slowly. And then if you've got a resynchronization pacemaker, this is the third lead. So it goes down this coronary sinus and just comes in a little branch that sits overlying the heart, and you resynchronize the heart. So if you've got left bundle branch block, you do very well with that. But there's new ones now. There's little tiny things that can go in the heart on the left or the right side without any leads. So if you've got access problems, they're incredible these days. And then ICDs. So we used to think ejection fraction less than 35%, you need an ICD. We're not sure what to do in dilated cardiomyopathy now because it seems the outcomes are better. And you may not, when you look at ICDs, there's not quite the difference we thought. And it may be only those that benefit are those that younger, healthier, and with scar in the heart. So the jury is out a little bit now, and you can see scar seems to be more important than your ejection fraction when you look at risk now. So we're changing how we think about putting ICDs in. And there's a trial going on called the British study. So dilated cardiomyopathy, ejection fraction less than 35%. They're randomized to either one of those little loop recorders or a defibrillator. So we'll know a bit more probably in about 3 or 4 years from that. And there's new types of ICD. There's a subcutaneous, sits at the side, just goes under the skin at the front. And the latest kid on the block is this extravascular ICD. Sits on the side, but it's tunneled up just under the breastbone. So you put the lead up there. And the advantage of that is, unlike this one, it can pace the heart, it can overdrive pace. So I think they're quite exciting, though, those new extravascular ones. Transplantation, we've had a wonderful talk already, but for those that are lucky enough, there's maybe 150 transplants a year. It's life-changing, isn't it? It's a fantastic thing to see. And we're still pushing nationally to start getting VADs as a bridge to transplant. Okay, so I'm going to whiz through that. This is just to show if you have leaky valves, we can fix those. If you have severe leaks of your mitral tricuspid valve, we can go up the leg and clip them now. You don't need an operation. If you've got aortic stenosis, we can put that from the leg with a new valve. So if you've got valve disease, lots of new options. And then just a bit about general health. So, you know, cardiovascular health, so coronary disease is still probably the commonest cause of death in cardiomyopathy patients. So you've got to think about your coronary arteries and your neck vessels as well. I'll just go through that. So if you have coronary artery disease and you don't have chest pain, you don't need a stent. Stents are just for chest pain. You don't get any prognostic benefit. So there's a lot of people without chest pain have had stents, probably for no reason. So just be wary of that. Don't smoke. Weight loss. So 1 pound of fat, 3,500 calories. So you need 500 calorie deficit for a week to lose a pound. It's very depressing, isn't it, when you do it like that? Yeah. GLP-1, so this is going to mainstream. So Wes Treating wants to give Manjaro, which is the new one, wants to flood primary care with it to get people back to work. So everyone's going to be offered these. And they look like wonder drugs, they really do. They improve quality of life. They seem to improve cardiovascular outcomes. You know, you obviously lose weight, but you seem to get benefits beyond that. And we've looked at, there's a semaglutide in heart failure program, and almost every trial has been positive. In terms of diet, Mediterranean diet trumps everything. That's the only one that's got an clearly shown outcome benefit in cardiovascular patients. So olive oil, tree nuts, peanuts, vegetables, lots of oily fish, have a bit of wine. But it's probably an antioxidant diet. Exercise, you need regular exercise, you need aerobic resistance and core flexibility, and you need to be active on top, which is getting the stairs, getting off at a stop earlier on the train. Alcohol, red wine's good for you. Well, no, it's not, sorry. Moderation's fine, but, if you look at the proper trials, at no point is alcohol good for your cardiovascular system, I'm afraid. And then just last bit, getting the most out of the NHS, what can you do as a patient? So do the self-care and monitoring. You need to know how to escalate if you've got symptoms. You need your consultant, your specialist nurse's contact, email, phone number. You need to discuss pregnancy, travel, driving, work. So have your letters on your phone, get a copy of your ECG, have your blood test results, think about before you go, write your questions down, make sure you're being seen by appropriate people, use the charities, use community pharmacists. The NHS is a little bit broken. If you take control as a patient, you get so much more out of the system, so you've really got to be proactive. What do you need to ask? What's my diagnosis? What's the underlying cause? Can I have genetic testing? Should my family be screened? Should they have gene testing? Am I being seen in the most appropriate clinic? Can I have copies of my tests? What's my EF? What's my prognosis? Can I stop drugs? Are there new drugs? Are there clinical trials I can be part of? Can I have tests locally? Where are the support groups? How much exercise? What's my personalised? You know, pick the 5 of those that really matter to you. Write them down beforehand. You know, and make sure you get the most out of your, because you know you only get seen every 6 or 12 months. You've got to make the most out of that. Very quickly, new therapies. Yeah, we've been through that. So stem cells, everyone always asks me about that. It's not there yet. This is a big meta-analysis. Probably no benefit from stem cells. But genetics, yes, because we treat down here when there's a problem. Perry's shown this earlier. If we do gene replacement, genome editing, silencing, you know, that is the future. Cure hearts, they got a little stall out there. But that's dwarfed by, you know, industry are throwing billions at this. A couple of people in Cleveland already had it. RNA therapies is probably the other promising area, actually. And look, here are the current gene therapy trials going on. So if you know, again, know your gene, because in the next 5 years, this will be important to know your gene. LAMP2, BAG3, PKP2, lamin, MYBPC3, all having trials in that. Okay, so, sorry, it's a bit of a whisper. The trials. The slides will be online, so, you know, you can go take a bit longer just to read through those. There's a lot more detail in the slides. So, got to be proactive. Genetic testing therapy is here, so be proactive about that. Healthy lifestyle, don't forget mental health. And if you have a weak heart, medical therapy is so important, and you need the right doses. Great, I should pause for breath.
Thank you so much, Gerry, for that fantastic talk. Now, what I failed to do was to say, if you had questions whilst Gerry was talking, write them down and put your hand up. Now, has anyone got questions? Right, so Becca is going to come around and collect the questions. But I might grab one because we're short of time. I'm going to go to Tina and I'm going to ask her question. It'll be a test of whether I can read your handwriting, Tina. Would you like to ask it yourself? And then I'll ask the rest.
Quite happy to ask it, yes. Hello, thank you. Does the advice that you've given regarding screening of family members and the advisability of it when a gene has not been identified as responsible vary according to the life stage of the family members? So, for example, if you have family members who are of childbearing age and likely to be having babies, etc., are they more likely to need to continue with the clinical screening than perhaps people where there's not so much change occurring? Thank you.
No, really good question. So, you know, if you have dilated cardiomyopathy and you don't have a gene, your family are a much lower risk. But we still don't know in that group when to screen or how often. But if you're 50 and you have one normal screen, that's probably enough. If you're 10, you probably should have another screen, 15, 20. So I think when you're at childbearing age, particularly if you're having children, probably at the moment we would screen a few times. The next step is some trials to actually look at this because they haven't been done. But no, you're spot on, actually.
Thanks, Gerry. Just following on from that, someone's asked if they have DCM and they have genetic testing which was inconclusive, so a variant of unknown significance, I presume, are they still at risk of a sudden cardiac arrest?
So I think if you have a variant of unknown significance, I think just look at that as a negative gene test. So you would sit within that better outcome population. So you're at less risk, but you're not at no risk. So every time you're seen, what we do is assess risk. What's your ejection fraction? How much scar on your MRI? Are you getting abnormal rhythms from your monitor? If your ejection fraction's okay, you haven't got much scar on your monitor's okay, your risk of sudden death is really very, very small. And you know, you're more at risk of heart attacks and other things, actually.
Okay. Somebody said there seems to be a lot of confusing information about survival which we've heard Perry mention. For an otherwise healthy young adult, can you say anything in 2 sentences? Probably one, I would think, about survival.
No, so I think, people, everyone thinks about this, isn't it? It's the one, particularly we've got young family and everything, you really want to know your outcomes. It's personalised. I have 10,000 patients I look after. The outcome for each one of those is going to be different. So when you have your consultation, you need to ask that question, but you need to ask someone that knows the answer, because your GP won't know your answer. A general cardiology registrar probably won't know the answer. So you need someone with enough understanding to answer that. But again, if you're well, you don't have a high risk gene, you're monitoring the echoes reassuring, your outlook is really very good. And in that case, most of the time you'll die from something unrelated to your cardiomyopathy, which is why you need to look after all the other bits of your health.
Okay, there's lots of many questions. We might not get through them, so I'm just quickly trying to summarise them. People are asking, concerned about waiting times for genetic testing, Gerry, and also what happens once they've got a gene positive result.
Yeah, no, waiting times are awful. They're trying to mainstream genetics, which I think for diagnostic testing is okay. But I think if you're doing predictive testing for family relatives, that needs a proper counselling process, because, you're taking a healthy 20-year-old and telling them you've now got this, life-altering gene. So diagnostic testing, I think, will get mainstream. Predictive testing is, you're waiting 1-2 years. So what you have to do is safety net that. While you're waiting, you have an ECG and an echo, just to make sure there's no disease expression.
Okay. Don't forget that we're also available throughout the day for questions if we don't get through them all. People are asking here about cardiac rehab. I know that is a problem because it's not accessible in all areas, but do you have any comments on that, Gerry? Yeah,
there's a big, so I sit on our national cardiology reference group. There's a big push nationally for cardiac rehab. We've released a lot of money for this. It should be available everywhere. And there's a focus on heart failure for rehab. So ask your GP, ask your local cardiologist. You should be able to access it everywhere.
Lovely. Thank you. Here's a nice straightforward one. Can we use our Apple Watches with our ICD?
Yeah.
That's the kind of question we like.
Yeah.
Okay. Another one about gene testing. We've done that one. I like this one. Who should make changes to your medication? So people often ring me about this. They might have been advised something by the GP and they want to check with their specialist. What do you think about that, Gerry? That's quite a tough question, isn't it?
It depends what the medicine is. So if, most of the time, sometimes you'll go into hospital because you're dehydrated, you've got a bit of renal failure, blood pressure's low. So then they'll stop some of your heart failure medicines, but then people forget to restart them. So again, that's one scenario we see a lot. I think if you've got a cardiologist that started you on medicines and a non-cardiologist wants to stop them, they do need to ask the cardiologist that's looking after you, because I've seen so many people where their medicines have been stopped and then they come and see me 2 months later in an absolute mess. So I would suggest that most of the time. And as medical community, we should be talking to each other, and we don't most of the time.
Okay. And this is another one about waiting time. Someone's obviously frustrated. Why might there be a delay in diagnosing my dilated cardiomyopathy?
There's a lot of young people who give great talks. They say, they had asthma inhalers for 5 years, went to A&E 10 times and finally got diagnosed. So particularly for young people, there are massive delays because people don't think of cardiomyopathy in young people. There are clear pathways. So if you have symptoms, you have this BNP blood test. If it's abnormal, you have an echo. That's what people should do no matter what the age or presentation. So if people follow the pathways that are there, people will get diagnosed. They don't get diagnosed because people aren't doing what they should be doing, really, is the short answer to that. Particularly if you're young, people don't think about it in young people. So yeah, I mean, you've got to keep asking the question, I think.
Thanks. I'm just going to ask a couple more questions, if that's okay.
Yeah,
Lots have come in. How concerned should people be about their ejection fractions? Quite a lot of people in the room knew their ejection fractions.
Yeah, a few bits about that. So most of the time it'll go up. So find out what your current ejection fraction is, not the historic one when you first presented. Most people it improves with therapy. Ejection fraction is one of the variables we look at. But if you take the most extreme example, so who gets a transplant, it tends to not be based on ejection fraction. It's more about your symptoms. So we do a cardiopulmonary exercise test and measure your peak oxygen consumption. We look at your kidney function, your BNP levels, and how often you're in hospital. So they're the things we use to decide who should have a transplant. So they're the real prognostic things. If your EF is low and stable and you're symptomatically well, I think that's okay, actually. It's a guide to devices. So at low EFs, you need to decide whether you need a defibrillator as a safety backup. But beyond that, I think those other variables are probably more prognostic, actually.
Okay. And one more question. People are querying vaccines. Do you want to say anything about COVID vaccines or too? Is that too tricky? Fair enough.
I think they're safer than people think. Everyone worries about people with dilated cardiomyopathy hear the word myocarditis with COVID vaccines, and that makes you worry. The risks of myocarditis with the vaccines is incredibly low. So I think they give you nasty side effects, but I think they're pretty safe. Overall, particularly, the risk of COVID is really related to age. So I think if you're elderly, I probably would have them. I think if you're young, it's probably a personal decision. That's not official NHS.
I know, it was a hard question, I'm sorry. I get that one a lot.
Yeah.
Okay. We should now be stopping for the break, but there's lots of questions. I will say some of them are very specific questions to yourself. Don't forget that you will have a nurse specialist as well as a consultant you can ask these questions to. So please do that. Let me see if I can pick one more.
So I'm happy to keep going, but if you're desperate for a coffee, please do just go and grab one.
Yeah, they're all genetic testing. We've asked that one. Let's ask this question. A patient who's been diagnosed with idiopathic dilated cardiomyopathy wonders how that changes their risk of their DCM getting worse. So is it different to other types of dilated cardiomyopathy?
Yeah, so idiopathic is a lazy term. It just means we don't know the cause. So the first bit in that is to be sure that they've looked for all the causes. So you need an MRI to look for scar, you need blood tests to look for all the things I talked about. And you probably do need genetic testing. So true idiopathic, you shouldn't have characteristic scar on your MRI. You should have negative gene testing and all the normal blood tests. In that setting, that the outcome's reasonably good.
Thanks. And are you able to talk a little bit about the current guidelines on genetic testing in children?
Yeah, yeah, really important. So again, two types of genetic testing. If you have a child with dilated cardiomyopathy, so they're the index case, it's a very good argument to gene test them because it tells you about prognosis and all kinds of other things. So in that setting, it's a good thing to do because you're not changing anything. They've got the cardiomyopathy. What's much harder is if you've got a gene in the wider family and you want to then see if that child is at risk of developing it, then that is a very individual approach. Depends on the family, depends on the child. You know, there's certainly cases we've seen where, you know, a 16-year-old child is furious he was tested when he was 8, because he's now living his life worried, and had he been given a choice, he wouldn't have been tested. So we err on the side of waiting till the kids are a little bit older and can have a say. Depends, but if it's a really high-risk gene and they might have problems before then you might say. So again, very individualised, but needs a proper long conversation in that setting, I think.
Yeah, it's a tricky one to discuss that. Could talk about it a long time, couldn't we?
Yeah.
Okay, I'm going to finish with, this is a nice abrupt question. What's the problem with dapagliflozin? Is that person talking about symptoms or how well it works?
So it works brilliantly in any ejection fraction. It's really well tolerated. The main side effect is, I think, that we see is these sort of fungal infections, sort of thrush, balanitis, things like that. But that's fairly rare. It's a great drug.
There we go. Okay, someone's very keen for this to be answered, and it's back to genetic testing. So that was a lot of questions on that. If a gene is found... I'm sorry, I'm finding it difficult to read it. I think what they're asking is, and you did cover this in your talk, if a gene is found in DCM, can it change my treatment?
Yes, it can. The high-risk genes, you would have a lower threshold for a defibrillator. That's the main thing. In the future, though, there will be genetic therapies. So most of genetic therapies are through an adenovirus, and you form antibodies, so you only get one go. So you probably don't want to be there at the beginning. You want to wait till the technology's there. That's just my tip for you. But,
okay.
Yeah.
Thank you so much, Gerry. You're an absolute font of knowledge, aren't we lucky?